Good afternoon. If you can hear me, I'm going to request you to just wave back at me. Good afternoon. Thank you very much. I would like to welcome you all to today's tele-echo session. I am going to be a facilitator. My name is Dr. Chirwa. And today we are discussing a very important topic, which is mental health in HIV. As we all know, mental health is part of what we call NCDs, but it's something that we rarely discuss. So hopefully today, with our subject matter experts in the hub and some of them joining us via Zoom, we'll try and exhaust this topic. So I encourage all of you to actively participate in this discussion. Our presenter for today is going to be Dr. Chirwa. She's a registrar in psychiatry, but we also have some subject matter experts, like I said, who are joining via Zoom. And I would like to mention that we have Dr. Simenda joining us. Dr. Simenda is a consultant psychiatrist, and he's also the National Mental Health Coordinator. Later on, we're going to have a case presentation from Dr. Onoya, who's one of the medical mentors, and the case is coming from Chirwa. So for now, briefly, we are just going to have a recap, and this will be given by Sister Mwamba. She'll tell us what we discussed last week, and the topic was ART in children. So Sister Mwamba can go ahead with the recap.
Good afternoon. Just a quick recap on what we discussed last week. The topic was on new updates in ART in children. We discussed on viral load suppression and linkage. We discussed that viral load suppression and linkage is lower in children in the native settings. We also discussed that flexibility with caregivers and adolescents is key to the service to our children. We discussed on weight-based dosing and granule have better palatability. Thank you.
So thank you very much, Sister Mwamba, for that recap. We are going to go straight into our presentation. So I'll just invite Dr. Chirwa to just briefly introduce herself, and then we'll start with the didactic presentation. Dr. Chirwa.
Good afternoon, everyone. As Dr. Naklira has said, my name is Dr. Chirwa. I'm a psychiatry registrar, and I'll be taking you through this very important topic. I'm actually surprised that it's a little long down the train of presentations, because it's a very important topic, and it's very crucial in, especially in the treatment and in our expectations for the outcomes in our treatment for HIV. So the learning objectives for this presentation will be to discuss the common psychosocial conditions that are seen in people living with HIV, and then also to go through the mental health issues on the quality of life, on how mental health affects the quality of life for people living with HIV, and also how it affects adherence issues to antiretroviral therapy. And then also we'll talk a little bit about how to address these mental health issues in people living with HIV, as well as the impact on antiretroviral therapy as well.
Okay, so we are going to go and share our first polling question. And the question reads, which of the following statements is correct? A, mental disorders may predispose individuals to HIV. Okay. May I just kindly remind everyone to mute your microphones? Thank you very much. So I'll start reading the question again. Which of the following statements is correct? A, mental disorders may predispose individuals to HIV. B, people do not develop mental health disorders as a result of HIV infection. Or C, mental disorders such as depression and anxiety are uncommon in people living with HIV. Or is it D, none of the above? So I'm going to launch the poll question. So what do we think about these statements? Do we have one in mind that is correct, or none of the above are correct? We still have a couple of seconds. We only have just over half of our participants who have polled in so far. We want to hear your views so that we can have an interactive discussion. What do we think about this person? Which statement is correct? Okay, I'm going to end the poll and then we'll discuss the results later on. So we'll go on to our second polling question. And the question reads, which of the following is, or are, if you feel there's more than one statement, true concerning mental disorders in HIV? Is it A, common mental disorders include mania, stroke hypomania, and anxiety? Is it B, people living with HIV may present with HIV-associated neurocognitive disorders? Or is it C, somatic problems, which include pain and sexual dysfunction? Or do we think it's all of the above? We have a couple of seconds. What do we think? Let's give our opinions. Okay, we'll move on to our third polling question. And the question reads, which of the following is or are true concerning Dolutegravir? Is it A, may cause psychiatric side effects such as insomnia, depression, and anxiety? Or B, psychiatric effects from DTG rarely warrant discontinuation? Or C, psychiatric effects from DTG usually occur in the first 4 months of initiation of therapy? Or is it D, all of the above? Which of these statements are true concerning Dolutegravir or DTG, as we usually call it, abbreviated? So far, no one's going for C. And we seem to be split between A and D. It's interesting, Dr. Chirwa. We have
A wide.
yeah, different answers. Okay, I'm going to end the poll now. We'll continue with the presentation. and then we'll come back to discuss the answers later. So Dr. Chirwa, can continue.
Okay. So I think we're all aware from working in HIV that there's definitely an interlink between mental illness and HIV. So for starters, mental illness may predispose people to getting HIV. So what we know is that mental illness will cause contributes a 4 to 10 times increased risk of getting HIV compared to the general population. And then some studies have actually said that 50% of people living with HIV have a comorbid psychiatric disorder. And then of note is that the mood disorders and alcohol and substance abuse will contribute a much higher risk when compared to the other mental disorders getting HIV. So mental illness contributes to increased risk behaviors, so that will account for more infections. And then as a result of mental illness, again, you get delayed or lack of testing, and then a lack of delayed and lack of initiating care, as well as poor retention when in care. And then it also brings about poor adherence issues. So ultimately, when you have mental illness, most likely you have non-optimal treatment, and then this will lead to poor outcomes. So the other interlink is that mental illness or mental health disorders may be as a direct effect of the HIV infection. And then the other thing to think about is that the ARVs that we use in treating HIV may cause mental health symptoms. So the common mental health disorders that we see in HIV are depression, anxiety. We also see post-traumatic stress disorder, and the depression, anxiety, we see post-traumatic stress disorder, and we see mania as well. And then the severe mental disorders are a bit less common compared to the common mental health disorders. And the severe mental disorders would be things like schizophrenia. And then we see a lot of substance use, misuse disorders, and then, of course, HIV-associated neurocognitive disorders. So the issue, I think, with HIV and AIDS and mental health is that it poses a very big challenge, because already we have stigma in HIV treatment, and then we have stigma as well in managing mental health issues. So it's sort of double trouble, if you like. It's a double stigma when it comes to mental health. So the psychosocial issues that come up in people who have mental disorders would be that they have increased social vulnerability, and then they have altered risk behavior. And then there's a link between substance misuse and mental disorders that will again predispose to risky behaviors and adherence issues. And then there's also a loss of control within sexual relationships. So they're not able to make informed choices and controlled choices as compared to the general population. And then there's the issue of adolescents and women. So adolescents and women are of note because the adolescents tend to show higher symptoms. So if it comes to, say, depression, for instance, you find that they're more prone to depression compared to the general population. So being an adolescent in itself is a risk factor, and as well as being a woman. And with women, there's also the issue of abuse as well coming in that predisposes women to getting HIV. I think this is a repetition of the slides, but so when you look at literature, what it shows is about 26 to 36% of people living with HIV. And studies in South Africa have shown that so up to 38% of people who have a common mental health disorder. And then it also they also show us that at any given point in the course of illness, about 25% of people living with HIV will have some form of depression. So whether it's mild, moderate, or severe depression, 25% of people living with HIV will have some form of depression. And a study by Dr. Besa and colleagues done in Zambia showed that the burden is about 17.3% of patients with HIV have a comorbid mental disorder, the commonest being alcohol dependence and abuse, followed by depression and anxiety, and then mania. So mental health in HIV is a very wide topic, and I chose to focus a bit more on depression because especially that it affects mortality. So, and then the other thing is that it's the most studied in HIV, and then we know that it's one of the leading causes of disability worldwide. So these are a few examples of some studies that have been done, and one was done in Tanzania that followed up almost 1,500 women, and it showed that 6.6% of the women who had depressive symptoms were at risk of mortality compared to 3.7% who were at risk of mortality who didn't have depressive symptoms. And then in the United States, they did a study of almost 800 women that showed that women who had depressive symptoms were 2 times more likely to die as opposed to women who didn't have depressive symptoms. So even if you took into consideration things like CD4 count, etc., you found that people who had depressions were twice as likely to die from the disease. Another study showed that women were 3 times more likely to die when they were on ART, and 7 times more likely to die when they were not on ART, but had depressive symptoms when they were compared to those who were on ART, but without depressive symptoms. So what it tells you here is that antiretroviral therapy has a role in reducing the mortality, but you still have 3 times more women dying even on antiretroviral therapy compared to those who had no depressive symptoms. So another study showed that with each 25% increase in days with depression, so meaning that the more somebody stays with depressive symptoms, the more likely they were to succumb from the illness. So the other issue is that it's been well documented that people who are depressed generally have poor adherence issues. Lots of studies have shown that people who have depressive symptoms tend to have poor adherence, and we can even be basic things like symptoms of depression, being forgetful, having low mood, having no energy even to come and get their medication, etc., etc. And then the second point is that, again, this point just shows that in adolescents, they are more likely to have, they were shown like 25% more likely to have more depressive symptoms compared to adults.
It's live.
So the other disorders that we see in mental health and HIV, anxiety disorders, they're very common. I picked on depression just to give us an overview, and I'm hoping that maybe with time we can look at each and every one of them, because we see a lot of people with anxiety disorders. So they come in the form of generalized anxiety disorders, panic disorders, and then we see a lot of alcohol and substance abuse. Again, this is a very big and wide topic that will need its own time, because there's a big interlink between alcohol and substance and HIV, be it predisposing, and then be it as a result of maybe a depression that comes out of chronic illness. And then stress disorders, like I mentioned before, of note here is people who are abused. And then we see a lot of problems, somatic problems. So these will include sleeping disorders, sleep disturbances, and then pain and fatigue, as well as sexual dysfunction. So we'll move to what to do when you're assessing somebody who's got mental health disorders. So we believe that this should be routine. So all patients who come in and have HIV should be assessed for mental health disorders. The numbers have shown So it should be routine, and good history and the mental state examination should be done, I think, at initiation, and that can be used even as subsequent reviews as comparison. And then there's also a need to use screening tools because these are standardized, and then we can use them also in terms of monitoring the progression. So we have a lot of screening tools. I listed a few. Of note is the Patient Health Questionnaire. It's for depression. It asks 9 questions that are symptoms of depression. We have a shorter version of that, which is a Patient Health Questionnaire 2, which only has 2 questions that could be used by any healthcare providers. It will ask about symptoms of depression. So are you depressed, and have you lost activity? Have you lost interest in regular activities? And you give pointers as to whether you need to do a further assessment. We have other screening tools that we use for alcohol, that we use for anxiety disorders, and also just general health questionnaires. So this is just an example of the patient healthcare questionnaire and the scoring and how you can assess to see whether it's a severe depression or they have some moderate depression and the like. So this is the shorter version, which is the Patient Healthcare Questionnaire 2. It only asks 2 questions, loss of interest and also for symptoms of depression. So I put a slide for gender-based violence because I think it's a big issue, even in our setting, although the data that I got was from South Africa. And they've shown that there's a high prevalence of gender-based violence in the women, especially in the women who are accessing care. And they've suggested that we screen for gender-based violence so that we are addressing it also in our treatment. So some of the questions you could ask are, how are things going in your relationship with your partner? And have you ever been emotionally or sexually or physically victimized? So again, in the management, so it's very important that you do a mental state examination. The management of patients with mental illness is always what we call biopsychosocial, meaning that we screen for biological factors. We do blood tests. The patient may have hormonal discrepancies that may be leading to the mood and the CD4 count and the viral load. We all know that CD4 count and viral load will tell us at which point the patient is at, and also are predictive as to whether they will develop a psychosis or not. And then also it's very important that patients with HIV are treated with ARVs. So we've seen that patients with mental illness, especially as a result of HIV, don't improve unless they're treated with antiretroviral drugs. And then, of course, we'll give them medication for mental disorders if they meet the criteria. So whether it's antidepressants, whether it's anti-anxiety drugs, whether it's anti-psychotic medication, we'll be able to do that. Another important part of management is the therapy. So the therapy depends, and we've got different types of therapy that we use. So it can be interpersonal therapy, we can use what we call cognitive behavioral therapy, we can use group therapy, and then, I think of paramount importance, especially in our setting, is that, you know, the social and the family support is also emphasized. So this is just the flow of the approach to management. So you have assessment, so you assess and then you utilize tools to be able to make a diagnosis or point to a diagnosis. And then you identify who needs intervention and then what type of intervention do they need. So do they need drugs? Do they need therapy? And then you can initiate treatment and then you can refer. So on the refer part, it's very important because then the new Mental Health Act actually states that only a psychiatrist can treat mental disorders for over 6 months. So when you're going over the 6 months period, you have to refer to the psychiatrist. So antiretroviral drugs, antipsychotics, and psychotropic drugs all have side effects. And what we know is that patients with HIV have a high risk of developing what we call extrapyramidal side effects. Extrapyramidal side effects are what we see primarily with antipsychotic medications. So people who have HIV are at higher risk of developing side effects. And then as with all drugs, there's obviously interactions that occur. And I think what is important is to just know that there are interactions, and you can always quote the BNF or always go back to look what the interactions are. I think it's impossible for you to pinpoint every possible interaction. And most of the time it's because of the cytochrome P450 system. So because most of these drugs are metabolized in the liver, so either they'll be reduced or increased. And especially if they're increased, can bring about more side effects. So we have to look out for those things. And then the other thing is that our psychotropic medications, as well as ARVs, they both have a risk of metabolic syndrome. In other places, they've suggested the use of metformin. So when you're initiating, depending on the risk, depending on the insulin resistance and risk of diabetes, for instance, you could add metformin. But it's just important to know that they both predispose to metabolic syndrome. This chart is just to show you the drug interactions. So these are the antidepressant drugs, amitriptyline, fluoxetine, and sertraline that we commonly use in our setting. And what it shows is that levels of amitriptyline may be increased when you use them with your protease inhibitors, for instance. So it's just saying that in patients with HIV, it's maybe key for you to start at a lower doses and titrate upwards. Okay. So this is a new drug that has been introduced in the treatment of HIV as a first line, Dolutegravir. And so of note is that it has some psychiatric side effects that were like insomnia, depression, anxiety, and then also increased levels of suicide. But they were not significant to warrant discontinuation. So as with every drug, they'll report some side effects, and they were less frequent, for instance, as compared to those taking Adherence. What the studies have also shown is that all these side effects will usually occur in the 4 months of initiation, and then especially if there's no discontinuation, will sort of subside. And I found one case report on sodium valproate, and I think further studies need to be done, but I thought it was important to mention it because it said that this patient was taking sodium valproate was found to have subtherapeutic levels of Dolutegravir. So in summary, I think this is a very important topic, as we've mentioned before, and that psychiatric conditions generally are undertreated in chronic disease, and in this case in HIV. And then HIV and mental health go hand in hand, they're interlinked. So you have to deal with one to deal with the other. And then that healthcare providers should be familiar with the common presentations and the management of psychiatric conditions in HIV. And they also should be familiar with neuropsychiatric effects of medications and the drug interactions. And that the management of of patients who have mental health disorders in HIV will always take a multidisciplinary team approach. So it will be a biopsychosocial approach. Those are some of the references. And my details. And I think Gabriela will take it up from there, and then we'll discuss more, I think, when we're discussing the case.
Okay, thank you very much, Dr. Chirwa. I think that wraps up our presentation. A very, very interesting presentation there. It has raised a number of issues. I think before we go back to our polling questions, I just want to find out from the network, do we have any questions for Dr. Chirwa? Do we have any questions from the network for Dr. Chirwa? It's very interesting. I think we have patients in our facilities that we have been managing for mental health related disorders, living with HIV, and it's always a challenge when it comes to medication, either that being the ARVs or the psychotropic drugs. So I think this is our chance to, just be able to discuss as a network, what can we do for these patients? How best can we manage them? Do we have any questions? Okay. Okay, so we have a question from AADC, that's Adult Center of Excellence. You can please go ahead with your question.
Good afternoon, everyone. I hope you can hear us. Okay. Dr. Chirwa, job well done. Thank you so much. That was a great presentation. And I know I saw a comment coming from Western Province, that's Dr. Howard, who said we need to add these mental assessment tools to our guidelines. And I'm with people that work in the ACOE, and they're saying we don't have these tools. I know the issue with tools is validation. So which of those, I know you brought up BEX, you brought up something about the 9. Which one of those do you think would be most suited for our environment? What have other countries in the sub-Saharan region used that you would recommend?
Okay, thank you. You got the question?
Yes.
Okay.
So for instance, the PHQ-9, which is for depression, has been used in South Africa and in Malawi. So I think it's a good tool that we can use. It's primarily by the doctors, whereas the PHQ-2, which only has the 2 questions, is another tool that can be used. Actually, currently at the moment, one of my colleagues is doing a study at Boston Clinic in women. He's using the PHQ-2 to screen for depression in pregnant women. So that's one I think that can be used, and that has been validated across the region. It's short, it's to the point, so especially for depression. Then the other one I think that can be used is the hospital tool for anxiety and depression as well. It's also a short tool. I know the surgeons are doing studies and they're using it in their brain pressure patients to screen for anxiety and depression. So I think that's another tool that we can use. In the clinic, we usually use BEX, depression inventory. I wouldn't recommend it because of usually it requires that the patient fills in and answers the questions. So I think it brings about a literacy issue in these 21 questions. So I think that's my comment on that one.
Thank you very much, Dr. Chirwa. We have a question. Is it from Dr. Sheikh? So Dr. Sheikh, kindly go ahead with your question. Dr. Sheikh? Kindly unmute your microphone and go ahead with your question.
Hello, can you hear me?
Yes.
Yes,
Hello.
Thank you very much, Dr. Chirwa, for excellent presentation. It has been great. And I think I have just few comments on the issue of the tools. I think somebody has just mentioned, and I think it will be very good that we should at least routinely screen these patients with HIV, at least for depression. If we cannot do for other conditions, but at least for depression, because it is so common among the people living with HIV. And the earlier we can start them on the treatment of depression, we can make our outcomes better. So it is highly recommended that we should include these tools, which Dr. Chirwa has mentioned detail in her presentation, that we should be screening these patients. It hardly takes 2-3 minutes more in the screening, and we can dramatically improve the outcomes if we can put these patients on the treatment of depression. I think that's what I wanted to mention.
Thank you very much for your comment. And I think Dr. Chirwa did spend time talking about depression and how depression obviously affects adherence in patients that are living with HIV. And of course, you mentioned other mental health related disorders that we need to pay attention to. But as we know, I think depression is one of the most common disorders, and we really need to address it, even as we are looking after our patients in our day-to-day lives. Okay, I think at this point, if we do not have any more questions, we are, okay, I'll allow a comment from Dr. Simenda. Like I said, Dr. Simenda is a consultant psychiatrist. So Dr. Simenda, go ahead and unmute your microphone.
Dr. Chirwa, thank you for the presentation. It's all clear and nice. I just wanted to add, commenting on Dr. Shisha's request. Looking at ART, we already have a number of forms that are included when initiating a patient and follow-up. So when we look at mental health, and because the diagnosis in mental health is not only depression, but there are many other conditions. Like at Chainama, we identified about 10 common HIV-related mental and psychiatric disorders. So the two that we could make a hybrid of is the mini that diagnoses about 27 conditions. So we could get the min kit for children and the adult and make a hybrid for Zambia, and preferably maybe on the A4 size, just one page, that can be included amongst the ART forms. I think it's a very good suggestion which we should take up. Thank you.
Thank you, Dr. Simenda. I just have a follow-up question on that. How user-friendly is that tool? Is it something that our healthcare providers will be able to quickly administer as they're screening these patients?
Yes, yes, Chair. In fact, the mini was designed for non-psychiatrists in the US. There is a tool which is called the SKID. This has like a 4 categories.
Seem to have lost connection there a little bit.
Of questionnaires, and it's really detailed, but this is more recent in such that you can use the mean tool, which was the last one that she listed on, is designed to be used by healthcare workers and most people who can understand English, and it screens for almost all mental disorders, and that's the advantage. So it will not only screen for depression, but it will screen for acute psychotic disorders, schizophrenia-like symptoms, depression, even the big one, the HIV dementia. So it will screen for almost all conditions, even childhood conditions, conduct disorders.
Okay, thank you very much, Dr. Simenda, and for all the other participants for your comments and contributions. I think hopefully we would love to have a bit more sessions regarding mental health in HIV. So I think I'm just going to poll our questions again. And we'll start with the first one. The first question reads, which of the following statements is correct? So option A, mental disorders may predispose individuals to HIV. B, people do not develop mental health disorders as a result of HIV infection. C, mental disorders such as depression and anxiety are common in people living with HIV. Or is it D, which is none of the above? So after our discussion, what do we think? So we have a few seconds. Let's keep voting after our discussion. What do we think? What have we managed to pick so far? Okay, so 89% of the participants think the answer is A. What do you think, Dr. Chirwa? What's your comment?
So the answer is A. So mental disorders may predispose to individuals living with may predispose individuals to get HIV.
Okay, so quickly we'll go to our second poll question. I'm going to relaunch it. And the question reads, which of the following is or are true concerning mental disorders in HIV? Do we think it's A? Common mental disorders include mania and hypomania and anxiety. B, people living with HIV may present with HIV-associated neurocognitive disorders. Or is it C, somatic problems, which include pain and sexual dysfunction? Or do we think all the above are correct? Interesting.
Okay, so I think this one is a bit of an ambiguous.
I'm gonna end the and then yeah, this is how we put.
I think it's a bit ambiguous because so I think all the above are true. So A is true, B is true, and C is true. I think it's just interesting that maybe some think HIV-associated neurocognitive maybe are more common, but all the above are true.
Thank you. So we'll quickly move on to our third polling question. I think initially here we had the split of answers. The majority went for A and D, but what do we think this time around? Which of the following statements are true concerning Dolutegravir? Is it A, may cause psychiatric side effects such as insomnia, depression, and anxiety? Is it B, psychiatric effects from DTG rarely warrant discontinuation? C, psychiatric effects from DTG occur usually in the first 4 months of initiating therapy? Or is it D, all of the above? Okay, so 88% think it's D.
Okay, so I'm happy that the majority now think that it's all the above, which is the right answer. So DTG does cause insomnia, depression, anxiety, and then the side effects usually are not that severe that it will warrant discontinuation. And yes, they will usually occur in the initial parts of treatment.
Okay, thank you very much. I think we are going to move on now to our case presentation. Chawama, just get ready to share your case. Dr. Onoe and the team, can you hear us? So, Chawama, can you hear us?
Yes, we can hear you, Doc. Are you able to hear us?
Yes, we can.
Good afternoon to everyone. We are going to present our case, and the presenter is Editor Mwinga.
Okay.
Yes.
So, Chawama, we will kindly ask you to just stop sharing the case. We'll share from the hub. Okay. So just stop sharing your screen, and then we'll share from the hub. Okay, thank you very much. The presenter can go ahead.
Good afternoon, everyone.
Good afternoon.
To present the case, I'm Editor Mwinga from Chawama, ART.
Okay, go ahead.
Yes, we are presenting a case of a female, 45 years, enrolled on ART on a TLD since March 2019. She's violent and not cooperative. Brought in by relatives who said she has been in the state of more than a year now. Tested from OPD and sent to ART clinic for assessment and initiation of ART. She presented with rash, which are like small macules all over the body. She has never been married. She has no child. The education levels were grade 7, according to information. Client is living with the sister, who is reported to be not caring much. She's been taken care of by her nephew, who is her buddy and does not miss pharmacy pickups. The client is reported to demand for her drugs to take whenever it is time, but she doesn't accept to have blood drawn from her because of her religious beliefs. She's a Jehovah's Witness. There's a family history of drug abuse, cannabis and alcohol. Most of family members have been to Chinama for medication or rehab, including the nephew who is her buddy now. No history of fever, headache, hallucination, cough or neck stiffness, client eating well and able to walk without support. Then on the vitals, the height was 177 centimeters. The weight at the beginning was 65 and now she's 67. BMI, as shown there, the temperature, the pulse and the rest were normal. The vitals, weight, height, general appearance, mental status, they were as shown seen previous slide. Look health, order compared to her age, and rest sometimes. The mental status, she was oriented, she could know that this is a facility. The memory is normal, attention disturbed sometimes, intelligence normal, station normal, gaze, anxiety, tremor, absent, tick, absent, speech was normal also. Language, there was no language barrier, no abnormalities detected. The limbs were all intact. Then the client was initiated on TLD on 9 March 2019. And she was tested HIV positive on the same date when we initiated her. The CD4 was taken, though she was violent at the time. We managed, with the support from other people physically, we managed to get the CD4. The VO, we are unable to do the viral load. She was supposed to do the VO in September 2019, but the client refused to have blood collected. As we mentioned earlier, to say she's, whatever her beliefs, she will complain and they shout and things like that. The patient, we referred the patient to Chinama so that maybe by rehabilitating her, we could be able to do the VO after Chinama treatment. Creatinine wasn't done, RPR was done, it was non-reactive. AOT, AST, it wasn't done. The limitations in the case, most of the lab investigations not done because of the same violence towards health providers when attempting to beat her. Family reluctance to send the client to Chinama, they are doubting. So we have some questions to ask so that we can be helped in this case. So our questions are, in the absence of signs and symptoms of meningitis, should we perform the lumbar puncture for more investigations? And the second question is, how do we monitor such mental and stable and violent clients whose family doesn't want him to go to psychiatric hospital?
Thank you very much for that case presentation. I think this is a very interesting case. So in summary, we have a 25-year-old patient who was diagnosed with HIV in March 2019, identified via OPD, linked to ART, assessed and commenced on ART. And we've heard that this patient somehow being, well, you can say followed up by the primary care doctors for what seems like a mental health related disorder. And patient was actually at some point referred to Chinama and has been on ART, said to be adherent, actually demanding for the drugs when it's time for her to take the medication. And this patient has been on ART for more than 6 months, due for an assessment, but patient has refused to have blood drawn from her. I think this is probably going to be a very interesting discussion. I would like to invite comments and questions from the network regarding this case before we answer the questions that Chawama has. Are there any questions, any comments from the network? I would just like to find out how the preparation and the assessment and the readiness to start ART, how that was done, who brought the patient initially to the facility. Maybe you could enlighten us a little bit on that.
Actually, the relatives brought the client to OPD, and the OPD, they tested the HIV, and then when they found it's positive, they brought the client to ART for initiation. Actually, it's the family members.
Also, it's the family members. Okay. Yes. So we have a question from HNPs in Chinyunyu. You can go ahead with your question. And then we'll have Dr. Sheikh, and then we can try and get to
Good afternoon.
Good afternoon.
Yeah. I just want to find out if, or rather a clarification from Chawama, if really the parents, I mean the people are looking after the patient, declared to send the patient to Chinama, or they're just reluctant, especially that there's history of family having some mental disorders resulting from drug abuse. So if they are just reluctant, I would urge them just to make a follow-up and encourage them to send the patient to China. Thank you.
Okay, so from Chinyonyo, if I got it correct, you wanted to find out if the relatives are reluctant and why, and you're recommending that probably they can be to try and make sure that the patient gets the necessary care?
Yes, please.
Okay. So, Dr. Sheikh, you can go ahead with your question.
Hello.
Hi, we can get you.
Yes, in this case, you know, the history is not very clear. We need to get a proper history, especially, you know, there is a strong family history of mental illness and drug use. And if I look at the history, it has not been clearly mentioned about the drug use in the patient. Does she take any alcohol, cannabis? Is there any history? And then the other thing is, when does this violent behavior come in? Because I'm sure the patient is not violent at all the times. We need to find out what is really the cause of her violent behavior, in which situation. Is it only when somebody tries to get the blood? Is this only the time when the patient gets violent, or are there in any other situations when she gets violent? And the other thing is that, you know, it is very strange that she is even taking her medication. So that's a good sign that we can manage her, you know, as if the patient can take her ARVs. I'm sure if we put her on any antipsychotics, she might be even able to take the medication. So we need a very good history here. You know, we need to get a proper family history. We need to get a detailed history about the patient. What really came in first? When, you know, before she was diagnosed with HIV, was there any symptoms of any mental problem? We really need to establish what came first in this patient. Is it the HIV or is it the mental illness? then we need to explore her for the drug and alcohol properly. And then, you know, all these are the missing information in this case, which I think Chawama should find out before, you know, we manage this case. Thank you.
Thank you very much, Dr. Sheikh. Chawama, I'm just going to give you a chance to respond to the questions. I think that one of the questions is similar to what Senanga Urban is asking. What came first, the mental illness or was it the ART? Chawama?
Yes, when this grant was brought to ART, as we were just given to initiate ART. So we don't know really if OPD was taking care of this grant before, but when we were given this grant, we had to start what we know best. So we just had to start. Though at some point we advised the family to take the patient to Chainama.
Okay. Was it a case of same-day ART initiation?
On the same day, we initiated and also we tried to do the blood collection, where we had to hold the client so that we could manage to draw the blood.
Okay, so the first time you managed to draw the bloods, but you had to restrain the client.
Actually, the issue of holding her, managing her with a lot of men around.
Okay, I guess we'll get a
And there was another question where they said, when is this client violent? Actually, sometimes I could manage to talk to her. We could discuss and she could agree. And at some point, I even prescribed some cream for her skin rash, which is gone now. And even the weight has improved. But there are times when you just talk of blood, it's another issue. And there was also one time when we were trying to do, without my knowledge, some people tried to take her for cervical cancer screening. Also, she was very violent. So those are the times.
Oh, okay. Dr. Sheikh, has your question been answered? I think there was also a comment to say we need to get a bit more detailed history regarding the family history. We have heard that. Yes, Dr. Sheikh, is saying, has your question been responded to, or at least part of it?
Yes, it is. You know, it's a part of this question has been answered. You know, I think that's where we have problem in Zambia, that we are not screening these people for mental health problem. So it's not, you know, we can't really blame Chawama for that. You know, once we initiated this patient on the treatment, there was a need to explore, to assess, you know, to do the complete mental state examination, to find out about her psychiatric problem, because this patient, you know, the way they are saying, I think she came with the with some mental health issues. And as far as her violent behavior is concerned, you know, the way they are saying, most of the time it is coming when we are trying to do some lab investigation. You know, we can hold on to these issues and we can explore the patient, try to establish some rapport, be empathetic with the patient, try to talk to her nicely, get some detailed history. What is missing in this case is a detailed history about her mental health issues.
Very good. We have a from Howard. Howard, you can go ahead with your question.
Hello, can you get me?
Yes, we can.
Okay, I think part of my question has already been raised by Dr. Sheikh. I think this case shows us the need for us to be doing mental assessment, because we have seen a lot of gaps. I think we have gone more to the than treat and forgetting part of other comorbidities for our patients. And I think for this patient, we can see that we didn't probe further. Just on the right and so they checked the level of intelligence, which they said was normal. Which tool was used to check for level of intelligence. But nonetheless, I think there's need to provide these tools in our hospitals to ensure that we do assess these patients, because a lot of them really move with these personality disorders. And I think Dr. Sheikh has put it, there's a strong family history associated with this. So we need to go back and get a proper history from our patient, I think, to be helped. But I think most of my concerns were answered by Dr. Sheikh. Yeah, thank you very much.
All right. Okay, we have a comment from Nathan, and Nathan wants to find out what are the measures that have been put in place on the part of the providers, as the healthcare providers, as well as the caregivers, to ensure adherence to treatment in this patient. So Chawama, would you like to respond to that?
The question, please. We couldn't hear you.
All right, so the question is, what measures are there in place on the part of the healthcare provider and the caregiver to ensure adherence to therapy, adherence to ART in this case? Is there anything in particular that you've put in place?
Yeah, before, I don't know if you allow me before answering to this question, I would like to make an addition to what my colleague has just said. So when the client came at the facility, she was not brought for a mental concern. It was for something else. Then the client was tested for HIV and found positive. So when they came to the ART, we agree. We agree with you that the mental assessment was not correctly done. And I think it shows also the need for us to update, if not enrich our the smart care, because that mental component, I think it's missing. And we can only do what the smart, since the facility is EFS, we can only do what the smart care allows us. So there is a need for us to reassess the client. And I think the next appointment is in January. I don't know if we have to go back the client before the next appointment, or we have to wait for the next appointment for us to do that. Going back to the issue of adherence, when we look at the drugs pickup appointment, the client has not yet missed any appointment. Even in terms of, if I can say, swallowing drugs, it has been mentioned that the client can even request for drugs when it's time for her to take them. So far there's no issues regarding the adherence. The challenge we are having is bleeding so that we can perform the viral load testing and other investigation. Thank you.
Thank you very much. We have a question from the hub. You can go ahead, Mrs. Makope.
Yes, I wanted to find out the diagnosis of mental disorder in this client was based on what?
Did you get that, Dr. Onoy and the team? Very, very brief question.
Yeah, so when I think we didn't answer to this question. Before even the HIV diagnosis, there was that issue of violence in the family, in the community. We also mentioned the history that some of the family members have been even at Chainama, but even the patient himself, there was that issue of violence, and sometimes the patient was unrest. Yeah, it was also a type of violence. Then even when we were trying to give the patient, that issue came up. But I think even when you are talking to the client has got some judgment which shows that mentally the client is not stable.
Okay, just a follow-up question on that. Was this patient yes, who has refused to have blood collected? And of course, we've heard that there have been issues of, partly related to religion. We don't have the full details, but can we go this route, sedate the patient and get the samples? Medical legal issues, what's your comment on that?
Maybe let me just, am I allowed to just summarize the case the way I understand it?
Yes.
Thank you. So we are given a woman who is 45 years old and she's unmarried. She dropped out at grade 7. She has no children and she's under dependent care. And this shows us some elements in the social demographic profile. She has a history of positive mental disorder in the immediate family. And in the history, we are told a 1-year history of violence, but we don't know the details. Is this physical violence? Is it verbal violence? And this uncooperativeness. Anyway, our judgment here is that she shows consistently an altered objects relations. That is a paranoid type of delusion. She does not trust anyone and she does not trust what they're doing to her. So she does not cooperate to the blood taking. But we also note here that very quickly the patient has a lot of level of functioning in terms of mental capacity. She's able to know that she's HIV positive. She comes for the reviews and collecting her medication, but on abstract thinking and judgment to say that she needs a viral load, she cannot relate with the healthcare workers and understand. That's where the objects relation comes in. It is paranoid in nature, and we are looking at it that she thinks she's being persecuted in some way or some other. So what is needed is to establish this delusion. And if a delusion is on for more than 6 months, 1 year, then just on
Okay, I think we seem to have lost connection with Dr. Smenda there.
that point. So, oh, sorry. I was just reiterating that she's had this delusion for more than a year. And in psychiatry, we qualify that one delusion, and maybe it is even systematized not only to viral loads, but to many other aspects of her life. She does not trust people, she does not, you know. So we say that she has a delusion and it's a paranoid type. She most likely has paranoid schizophrenia. And these people are usually very functional. They look well dressed. They go on, and this could have been going on maybe from the mid-20s, or indeed it came at 44, like they are suggesting, or it's been ongoing. So she needs this treatment, but as Dr. Sheikh suggested, it's always good to now take a thorough history and mental state examination. I like the team at Chawama. They already did their best. They were able to observe abnormality. So just to start with, they were able to see that her abstract thinking and the judgment was poor. So that's a good thing. And they were able to know that the reasoning was not consistent with normalcy. So the abstraction is poor and her cognitive functioning is a bit low, and she has a delusion. So the specialist will just elucid whether she also has hallucinations and for how long. And now the choice of the antipsychotic would depend on what can work well for her, judging from the comorbid factors. How good is her vital organ state, the liver, the renal system, and also the heart. So we might choose a drug because, mind you, antipsychotic and psychosis. So I think it's something for another day. I may want to pause there, but it's a very interesting case which we could go on in the dating.
Sure.
Should I answer the questions they've asked or later?
Okay. The questions. We just get one last question from St. Luke's, and then we'll go and tackle the questions. But before we proceed, just to get you clearly, the advice is we don't sedate the patient, but rather treat the underlying mental disorder. Is that right? Dr. Smenda? Okay, I guess we'll get back to us. St. Luke's, you can go ahead with your question, and then we'll answer the two questions that are from Chawama. St. Luke's, quickly go ahead with your question.
Good afternoon.
Good afternoon.
I just wanted to find out over the issue of them not for collecting the virus because the patient is not cooperative. I think we should also be considering the condition of the patient. This patient is not in a state where she can make her own decision when we look at or when we think of some ethical considerations. So I feel there are certain things that we can do in order for us to collect the blood samples for these patients, in order for us to know that the drugs are working or not. Thank you.
Thank you very much. I think Dr. Chirwa will be able to give us a guide on how we proceed with such issues bordering on, potentially medical legal issues. So, Dr. Chirwa.
So I think as Dr. Smith and Dr. Sheikh have said, I think the history was incomplete, and then we don't really have a good understanding of the patient. So in terms of the violence, is this patient violent all the time? So for instance, acutely when a patient comes in and they're violent, so they're a threat to themselves and they're a threat to those people around them. So you treat them as an acutely psychotic patient. So the management of such a patient would be different from somebody who's exhibiting violence sometimes when provoked, when irritated. So there are two different, very different scenarios. And I think from this case, we're getting a patient who's probably been chronically ill. As Dr. Smenda said, she's 45, she's unmarried. It seems this mental illness has been ongoing. So in this particular patient, I think de-escalation would be the best in terms of engaging with the patient and then probably initiating antipsychotic treatment. And hopefully you get them into a good mental state for you then to then counsel them for you to be able to collect the blood. Whereas if a patient comes in acutely psychotic and is violent, you manage them as an acutely psychotic patient, which will mean that you then you are warranted to sedate the patient and then take on. When it comes to medical legal issues, we've got the new act. I don't know if you've heard about it, the new Mental Health Act. So as healthcare providers, we can detain a patient for up to 72 hours. But first, we'd have to ask for consent from a proxy or a supporter or somebody who's the next of kin. If the next of kin is not available, is when we can then admit the patient and then institute care and be able to, we can then collect bloods and things like that in the context of that for up to 72 hours. If the patient requires longer than that, there's a whole process of getting permission from a board. So all those things are new, but I think the important thing for this case is just establishing the violence. Is the patient really violent? As I think the sister said from Chawama that she was able to engage the patient and talk to the patient. So possibly once the patient starts antipsychotic drugs, even after a few days, you'll be able to engage the patient and then institute therapy. And then, so I think that's my comment.
Okay, thank you very much. I think we'll quickly go to the questions that Chawama has, and then we'll, find out from Chawama if this discussion has been helpful. So, Dr. Simenda, the first question was, in the absence of signs and symptoms of meningitis, should we perform the lumbar puncture for more investigations? What is your take, Dr. Smenda and Dr. Chirwa, on that one? Dr. Smenda, you can unmute your microphone.
Good afternoon again, team.
Good afternoon.
Clearly, we have a patient that has been unwell for 1 year, been violent and uncooperative. And in your presentation, you have not shown us that she has symptoms of inflammation or acute illness. Okay? In 1 year, if this patient had meningitis, surely we know what would have happened to the patient. But if patients present in an acute phase within 1 week or so with the meningoencephalitis, that is, say, some meningism, a lumbar puncture may be indicated. But after 1 year, it's most unlikely. You may want to do just the antigen test for opportunistic infections of the brain. That would be helpful and indicate whether we have got an OR in brain. But the lumbar puncture most unlikely after 1 year. And these symptoms are happening in clear consciousness. That's usually clinically what we use to differentiate between functional psychotic symptoms and the symptoms emanating, you know, in neurocognitive symptoms emanating from organic. Organic means there's an infected organs like bacteria, parasite, and so on. If symptoms are happening in full consciousness, most likely you are dealing with a functional psychosis, which could be mental health and so on. But if there is associated rising in temperature, meningism, altered consciousness, even eye changes, and some
I think we seem to have an unstable internet connection. Okay, go on, Dr. Smena.
So that is the major distinction, is the period and the absence of other symptoms in full consciousness. So the lumbar puncture at this stage for this one may not be indicated. And for the family, we note that, yes, how could you go on with this patient? As suggested, would want really to establish this psychosis and start medication. Now, as it stands, the patient has a delusion, and the delusion is a psychotic state. From my own experience, if you don't have the good experience like an established psychotherapist, you may not want to engage in talking therapy with this patient. What this patient needs is an antipsychotic. As they settle down and their level of reasoning improves, that is when you can engage them in psychotherapies, the talking therapies together. Now, it's unfortunate that the family is fragmented and there is presence of mental disorder. And I think relying on this nephew may not yield much result. There could be need for family members that are actually older than this patient to establish a sustained treatment. So we need to, first of all, treat this psychosis, and then the psychotherapies can continue. That's my comment.
Okay, thank you very much. Anything to add, Dr. Chirwa, on this patient?
No, I think he has mentioned everything in terms of a lumbar puncture in a chronically ill patient who probably is got a primary mental disorder may not necessarily be warranted. And then we already know that she's paranoid and irritable when it comes to procedures. So I don't think it will yield much at this point in doing a lumbar puncture unless it was acute. And again, with the family, I think, like Dr. Smenda said, the nephew might not be the best person. And then there's also just need for educating the family. It may be that they don't understand what the conditions is, and then there's also that history of mental illness, substance abuse, and cannabis. So are we talking to people who are actually rational? So I think there's all those things to consider in the management of this patient. So.
Okay, thank you very much. So Chawama, we've heard from the discussion, very, very interactive. And I think so far, going by the two questions that you raised, the first one being, go ahead and if we should go ahead and perform a lumbar puncture, I think we've been guided there looking at the duration of symptoms. And from our evaluation of this patient, it is unlikely that this is a meningitis. So at this point, the LP may not be indicated. Of course, she's living with HIV, so you might want to, look out for other possible OIs. And in terms of how to move on from here, obviously, the diagnosis of this mental disorder has to be established. And I think we've been advised that we need to engage the experts. I don't know if we should engage both the psychiatrists and psychologists, or what's your advice on this?
So I think for this patient, you can actually refer to Clinic 6 at UTH, and then we can do our own assessment. And since the patient is taking ARVs, highly likely that they'll take oral antipsychotics. We'll monitor them weekly and see for improvement. Then we'll be able to institute other treatments if need be.
Yes, and then we've been advised that probably we need to help identify someone who's older who can help in taking care of this patient, because you've told us from the history, she lives with a sister, and the sister is not actively engaged in the care of the patient. And all this has been left to a nephew who also had, well, we can't say similar, but had a history of mental health related disorder, which he was treated for, and now he's more like a buddy. But is he mature enough to be able to take care of her? Do we need to engage someone? So if we need to engage someone who is mature, then I think that would be good. So Chawama, any last comments from you?
Okay, thank you so much for all the comments. I think we've learned a lot, and we also hope that any drugs we add to the treatment won't affect his adherence to the treatment, to the ARVs based on side effects. I'm with my colleagues here. There is Dr. Rupia who has got a concern. Maybe we can give him the opportunity to address it.
Yes, thank you so much. My concern is, in the initial, should we have deferred ART in this patient, having known that for a period of 1 year, there was abnormal behavior in this patient? So what was an emergency? Was it ART, or was it maybe mental illness we should have addressed? Because for me, adherence was compromised. That's that's my take. So in an event that we have a situation, even to the people out there, you have such a patient, which should come first? So maybe help me with that.
I think that's a good question. We are learning from this case. So going forward, if we encounter such a patient, what should we do first? Dr. Chirwa.
Like I was saying, I think that the two, you see, there's an interlink again. So the mental illness will worsen things, the HIV will worsen things. So I think a double approach for me would work. So I would start both ART and antipsychotics in this patient. As far as the antipsychotics, if it's a patient who is going home, I would start low, because we know that they are prone to extrapyramidal side effects. So you give a low dose and titrate upwards, and then see what the effect is. I mean, ideally you should have gotten the CD4 count, the viral load as well, to be able to establish at what point the patient is at. But I think I would, for a patient who presents like this, I would initiate ART as well as antipsychotics once you build out other things. I think the other thing that I wanted to mention was the alcohol and substance. We haven't really established much about the cannabis and the alcohol. And it's very important because those also can cause these symptoms as well. So they can worsen the symptoms that the patient is presenting with. So we can be treating with the antipsychotics and treating with the ART, but if we haven't established whether this patient is taking cannabis and or alcohol, these symptoms may go on. So it's very important that we tease out that history of the substance abuse.
Thank you. And how can we have access to the Mental Health Act?
Also, you can actually just Google it. It's online. If you just put Mental Health Act 2019 Zambia, it will come up, and then you can print it out or read it from
or download it.
Yes.
Okay. So we've been told it's readily available and accessible. I think we are going to end here. It's been interesting. Unfortunately, we cannot exhaust every question. We hope to have a second session and probably more in the future regarding mental health in HIV. A few announcements for next week. We are going to be looking at skin conditions in HIV-infected individuals. And we just want to urge all the mentors to help us look out for cases and submit cases for next week. Besides that, I just want to say thank you all for being such a very actively engaging audience. We hope to see you next week, same time. Thank you to the subject matter experts, Dr. Simenda and Dr. Chirwa. We'll be calling upon you again anytime soon.
Thank you.
Okay, so I'll say goodbye to everyone. and we'll see you next week. Don't forget to fill in your registers. Thank you.